Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Roche.
This program is presented by Medscape Education Global.
Hello, I'm Vas Sada. I'm a retina specialist based in Pasadena, California, and I'm delighted to co-chair this program with Colin Tan from Singapore. And together, we'll explore whether second-generation anti-VEGF therapies actually live up to the promise of being better drying and longer lasting. So this is our agenda for today. And so I'm going to start with a brief introduction of what we mean by these new therapies. Then Dr. Raj Mukherjee will tell us a little bit about how this affects our decision-making for wet AMD, and Hemal Mehta will do the same for diabetic macular edema. And then Colin and I will really talk about how this has impacted our clinical practice. And then Colin will wrap the whole program up and summarize and give us our conclusions. So let's get started then. And so our first order of business is, what do we mean by second-generation therapies? And to understand that, we have to first talk about what are first-generation therapies. And these, of course, are ranibizumab, bevacizumab, aflibercept 2 milligrams, and the biosimilar equivalents of these three agents. Now, what do we mean by second-generation therapies then? Well, these three are brolucizumab, aflibercept 8 milligrams, and faricimab. Brolucizumab features increased VEGF suppression. It's a small molecule that actually can be given in a much higher molar dose as a result. Aflibercept 8 milligrams also features an increased molar dose and also thus achieves increased VEGF suppression and does so also with a somewhat higher volume for injection. Faricimab also features a higher molar equivalent and thus greater VEGF suppression, but also hits an additional target in angiopoietin 2 or Ang2. And for that reason, I think it's important to maybe get into that a bit in more detail because we do recognize that VEGF is not the entire story when it comes to these various exudative maculopathies. Ang2 does seem to be relevant based on a variety of preclinical and clinical data. We know that Ang2 binds to the Tie2 receptor and ultimately leads to vascular instability by disrupting the blood-retinal barrier and with associated loss of the pericytes. And again, as I said, we know that Ang2 is relevant because certainly the levels are elevated in patients with these various exudative maculopathies. At the same time, though, I think it's important to emphasize that VEGF and Ang2 are probably also not the entire story, and I do think we can expect more targets in the future, and perhaps we'll have third-generation therapies that we can all look forward to. So with that, I should note that in the rest of the program, we'll be exploring when and why we should be using these second-generation therapies to really try to get the best outcomes for our patients. So up next is Raj Mukherjee with his insights on how we will use these therapies to manage neovascular AMD.
Hello, I'm Raj Mukherjee. I am an ophthalmic surgeon based in Leeds, United Kingdom. In this section, I'm going to explain how I make treatment decisions in neovascular age-related macular degeneration informed by the latest evidence and data. Now, when a patient is diagnosed to have wet age-related macular degeneration, the first thing we need to think about is what drug to use. Now, before we jump into what drug to use, there are factors to consider. There are social factors like how long the patient has to travel to get to the healthcare facility. How much does it cost to them or their family members to bring them in? Can they come in frequently? How is their overall health? Do they have dementia, which makes them difficult to come regularly? Then there are ophthalmic factors to consider. Do they have glaucoma? Do we have to avoid larger volume drugs in patients with glaucoma? Have they a history of intraocular inflammation? Do you want to harmonize, meaning both eyes being treated by the same drug? That might reduce the risk of drug mistakes. And finally, local policy. What are you allowed to use? What drug is going to be reimbursed? What does the license say? With all that in mind, for me, we generally start with the longer acting drug as the first choice medication. So aflibercept 8 milligrams or faricimab. And I base that on these studies, Voyager, Spectrum, far wide neovascular AMD and far retina neovascular AMD, which are real world trials. But I would also suggest that you may have to consider aflibercept 2 milligram as the first choice medication. And if you do, you need to know what is the evidence or what happens to these patients when you start them on aflibercept 2 milligrams. So there is a precise study which showed that after loading, about 50% patients will still have fluid in their retina if you start them on aflibercept 2 milligrams. So let's go into the evidence. So this is for aflibercept 8 milligrams. This is a Spectrum global trial. It's a 2-year prospective observation study. Most importantly, all treatment decisions were made by the treating physician. So what happens after loading? That's the 8-week data. So in treatment-naive patients, they got about 2.5 letters of vision improvement and significant reduction of central retinal thickness. However, in previously treated patients, the vision remained stable and there was a modest improvement of central retinal thickness. Now, in previously treated group, 70% of the patients had received aflibercept 2 milligram with a median time of about 3 years. If you go to 6 months data, it's very similar. There was no evidence of retinal vasculitis, no new safety signals. So to achieve this result, how many injections you have to do? So in treatment naive, about 4.7, so about 5 injections. In previously treated, about 4.5, so between 4 and 5. Now if we go to Spectrum UK data, which is again 24-week, 6-month data, smaller number of patients, these treatment-naive patients got slightly better vision, about 6 letters, significant improvement of central retinal thickness. If you look at previously treated patients here, they got a little bit of vision improvement and a modest improvement in central retinal thickness. Now, importantly, of the pre-treated patients, 60% achieved interval extension and 22.5% maintained, which means about 83% patients either remained at the interval or achieved interval extension. Again, very similar to the global data, about 4.5 injections needed over 6 months. So if we summarize that, the real-world summary of aflibercept 8 milligram use in neovascular AMD, after loading, you probably are going to get about 3-letter gain in treatment-naive patients. After 6 months, it can vary between 3.5 to 6. In previously treated, the vision will remain stable. But if you want to achieve that, you probably have to give between 4 and 5 injections in the first 6 to 7 months. Now, if you look at the faricimab data, now faricimab, the real-world trials have started earlier. So we have 2-year data. So this is far wide neovascular AMD, 2-year data. This is British trial, a large number of patients. Nearly 90% of the patients with previously treated arm had aflibercept 2 milligram. Again, about 3 years of this drug. And what did they achieve at the end of 2 years? In treatment-naive patients, there was a visual acuity gain of about 4 letters. In previously treated patients, the vision remained stable. Again, in terms of number of injections you had to give to achieve that, about 4.7, so about 4 and 5 in the first 6 months, in both the groups, in treatment-naive and previously treated. And that rapidly reduced over the months to about 2 injections in the final 6 months of the 2-year period. But more importantly, the treatment intervals increased. So people who started with 4-weekly treatment went on to go up to 9.5 weeks interval at the end of 2 years. And each interval, including the 10-weekly interval ones, also achieved 2-week interval extension. The intraocular inflammation and endophthalmitis rates in this group was very similar to the phase 3 trials. Even bigger trial is the FAR Retina, which is an American trial of faricimab, real world, 2-year results. Previously treated group had about, again, 88-90% of the patients, and almost half of them had vision acuity of 20/40 or better, so they are having good vision already. What did we see at the end of 2 years? In both groups, treatment naive or previously treated, the vision was stable, and there was modest improvement of central subfoveal thickness. How many injections? Very similar. 4.2 in the first 6 months in treatment naive, 2.6 in the final 6 months of the 2 years. So again, intraocular inflammation and endophthalmitis rates very similar to the clinical trials. Now, if you look at Voyager data, which is another faricimab real-world trial data, we have 12 months results. What was unique about Voyager is that deep learning-based OCT analysis was done, which means precise calculations of the fluid was done. 17 countries, usual care. Treatment naive group, they got a gain of 3.5 letters at the end of a year. Previously treated group, vision remains stable. And all sorts of fluids, so subretinal fluid, intraretinal fluid, it reduced in both the groups. The intraocular inflammation rate was 0.13%. Again, how many injections were needed? About 4.5 to 4.6 in the first 6 months, between 2.5 to 3.3 in the second 6 months, depending on which cohort you're looking at. So if we summarize all that, the real-world summary of faricimab in neovascular AMD, in treatment-naive group, after 2 years, the vision will probably remain stable or maybe 4-letter gain. In previously treated group, after 2 years, the vision remains stable. If we want to compare it with aflibercept 8 milligrams, the first 6 months we have data in both the groups. So you will need between 4 and 5 injections in the first 6 months, and then it will rapidly reduce to 2.5 to 3.3 in the second 6 months. So how do I treat my patients with neovascular AMD? I tend to start treatment-naive patients with faricimab or aflibercept 8 milligrams. I tell them they should expect between 4 to 6-letter gain in the first 6 months, and they will require between 4 and 5 injections. For previously treated group, the evidence is from these real-world trial is based on aflibercept 2 milligram used for about 3 years previous to switch. Again, you expect the vision to remain stable, and you will require a similar number of injections in the first 6 months, 4 to 5 injections. So then what is the benefit? The benefit is the treatment interval. So you start to use less frequent injections as time passes. If you are asked to use aflibercept 2 milligrams or biosimilar as the first line, then you can rely on precise study, which showed that 50% patients will still have fluid after loading. That might be a milestone visit where you may have to think about switching them. And if you are switching them, then what data you have after switching them? So the data is what we have already discussed. So in previously treated arms of aflibercept 8 milligrams or with faricimab using Spectrum, Far-Wide, or Far Retina or Voyager, the results, the vision will remain the same. You will need about 4 to 5 injections in the first 6 months of the switching. Thank you for your attention. Please continue to the next segment where Hemal Mehta will discuss evidence-based decision-making in diabetic macular edema.
Hello, I'm Hemal Mehta. I'm an ophthalmic surgeon based in Sydney, Australia. In this section, I'm going to explain how I make treatment decisions in diabetic macular edema, informed by the latest evidence. Significant visual benefit is possible with first-generation anti-VEGFs with intensive treatment. But in DRCRnet Protocol T, not all initial visual gains were maintained when patients returned to standard of care with a loss of 4.7 letters from year 2 to 5 using a PRN approach. The authors stated strategies to improve long-term outcomes in eyes with DME seems warranted to determine if visual acuity can be better maintained with different management approaches. The patients with diabetes have competing health and social demands, and we know that decreasing treatment burden helps improve patient adherence. We have been fortunate that our first-generation anti-VEGF agents have favourable safety profiles, but their durability is limited. We can see adoption of brolucizumab in real-world practice has been very low, despite a significant drying effect and durability in the Kingfisher trial. Uptake has been limited by safety concerns related to intraocular inflammation. In contrast, there has been a relatively rapid uptake of faricimab in routine clinical practice, and this reflects effectiveness, durability, and safety data. The data cut was too early to capture aflibercept 8 mg, but we would expect increasing utilization over time with this second-generation anti-VEGF agent. Let's take a closer look at the latest real-world data on second-generation anti-VEGF agents. Are they consistent with clinical trial data? And how is this data influencing my treatment decisions? The FAR-RETINA DME study is the largest real-world evaluation of faricimab effectiveness and safety for DME. It is an ongoing, retrospective real-world study using US IRIS registry data. In total, there are over 12,000 eyes with DME included. 60% of these were previously treated. The mean number of faricimab injections in the first 6 months was 4.1, decreasing to 2.1 in the second 6 months, and a further reduction was observed in year 2 for treatment-naive eyes. Similar decreasing trends were observed for previously treated eyes. The safety data evaluated were consistent with those previously reported in faricimab phase 3 clinical trials. FAR-WIDE is the largest retrospective real-world study of faricimab outside the US. The 2-year cohort included over 1,300 eyes. 73% were previously treated. Visual acuity improved by about 5 letters from baseline to year 2 in treatment-naive eyes and was stable in previously treated eyes. The median number of injections declined rapidly after the first 6 months of treatment in both treatment-naive and previously treated eyes. On average, there were 5 injections in the first 6 months and 2 in each of the subsequent 6-month periods out to 2 years. Intraocular inflammation and endophthalmitis rates were low and consistent with faricimab phase 3 trials. Voyager is a global prospective non-interventional study in patients initiating faricimab for DME. There were 150 treatment-naive eyes and 109 previously treated eyes with greater than 12 months of follow-up. Visual acuity improved from baseline to month 12 in treatment-naive eyes. In previously treated eyes, the mean central subfield thickness reduced over 12 months. The mean injection numbers decreased in the second 6 months compared with the first 6 months. And again, intraocular inflammation and endophthalmitis rates were low and aligned with faricimab phase 3 studies. The Voyager study, whilst collecting real-world data, has a robust imaging data set that's also collected. OCT imaging was analysed with a deep learning algorithm on a subset of patients to collect central subfield thickness, subretinal fluid volume, and intraretinal fluid volume at baseline and 6 months. Eyes treated with faricimab showed improved retinal anatomy in both the 66 treatment-naive and 34 previously treated DME eyes included in the analysis. There is potential to study prognostic anatomical factors in the future. Let's look at recent real-world data for aflibercept 8 mg. This IRIS registry study from the US included 2,280 previously treated eyes and 392 treatment-naive eyes. At the last observed aflibercept 8 mg injection, after about 6 months after initiation, median injection intervals were 11.7 weeks for treatment-naive eyes and 11.9 weeks for switched eyes. Switched eyes had a median interval extension of 2 weeks over prior aflibercept 2 mg therapy. In eyes with visual acuity better than 20/50, the median visual acuity change after 6 months of aflibercept 8 mg was a 5-letter improvement in treatment-naive eyes and stable vision in switched eyes. Spectrum is the first and ongoing global study to assess the real-world effectiveness and safety of aflibercept 8 mg in patients with DME. At week 24, the mean visual acuity improvement from baseline was 7.3 letters in the treatment-naive eyes, and vision was maintained in the previously treated eyes. At week 24, there was a mean reduction in central retinal thickness of 134 microns in treatment-naive eyes and 63 microns in previously treated eyes. No cases of retinal vasculitis were reported, and no new safety signals were identified. By week 24, patients in the treatment-naive and previously treated DME cohorts received a mean of 4 and 4.3 injections up to 7 months from baseline, similar to the faricimab real-world data. Up to month 7 in the treatment-naive DME cohort, 39% of patients received a total of 1 to 3 injections, 59% received 4 to 6 injections, and less than 2% received 7 to 8 injections. By week 24, patients in the treatment-naive cohorts had attended a mean of 1.2 injection-only visits, a mean of 2.8 combined visits, and a mean of 2.9 monitoring-only visits. The question is whether so many monitoring-only visits are required. Treat and extend is associated with fewer clinic visits, but must be balanced against the risk of marginally more injections. With a treat and extend approach, you can plan for the vast majority of patients having treatment, making it easier to plan appointments and staffing. Certainty of treatment also reduces patient anxiety. In Rhine and Yosemite, faricimab treatment intervals could be extended after the 4th injection. In Photon, aflibercept 8 mg treatment intervals were extended from the 3rd injection. Real-world data suggests that clinicians are confident to start extending earlier with second-generation anti-VEGF agents over first-generation agents. I'm willing to start extending treatment intervals after a loading phase of 3 monthly injections if there is a good anatomical response. Extensions in clinical trials and real-world data were most common at 4-week intervals rather than 2-week intervals in many of the first-generation anti-VEGF trials. This is reflected in the second-generation anti-VEGF real-world data presented here. In the active phase of DME, I use a treat and extend approach with 4-week jumps until I reach 16 to 20-week interval with disease control. I then transition to a PRN approach. Remember, when pausing anti-VEGF therapy, we need to assess for any development of proliferative diabetic retinopathy as well as recurrence of diabetic macular edema. In conclusion, reducing treatment burden is a key priority in the management of diabetic macular edema. Second-generation anti-VEGF agents offer a shorter loading phase and potential for extended treatment intervals. Real-world data supports the durability benefit of faricimab and aflibercept 8 mg over first-generation anti-VEGF agents, as seen in clinical trials. Thank you for your attention. Please continue to the next segment where Vas Sada and Colin Tan will discuss how second-generation therapies are impacting clinical practice.
Hello, I'm Colin Tan, a retinal specialist based in Singapore. In this section, Vas Sada and I will be discussing what impact the second-generation therapies are having on clinical practice. So the core question in this activity is whether second-generation agents are better drying and longer lasting versus first generation. Let's start with the first part of the question. Are they better drying?
Yeah, that's a great question, Colin. And one of the things we have to recognize is that most of the studies really weren't designed to answer this question. On the other hand, one thing that the pivotal trials for the second generations did feature is that they featured matched dosing phases, meaning that both the first generation agent, primarily aflibercept 2 milligram, as well as the new second generation agent, they're all dosed the same way, essentially monthly dosing in that loading or matched dosing phase. And certainly when we examine the trial data, we do see brolucizumab and faricimab did show superior drying. We didn't quite see that with aflibercept 8 milligram, although we have other information about that. I will also highlight that in the Kingfisher trial of brolucizumab, both brolucizumab and aflibercept 2 milligram were both given monthly for the entire duration of the study. And that was helpful in actually evaluating this question as well. And in that study, again, we saw brolucizumab feature superior drying compared to aflibercept 2 milligram. And finally, I should note that we have another study in Voyager, which is a prospective study, but a real-world study, really collecting data from around the world, which I think is also going to be very exciting. And the initial results of that look encouraging. Of course, very few patients have actually reached the follow-up time points, so we'll get a lot more information in the future. But so far, it does seem that we're seeing superior drying. So I would say, on total, the second generations do appear to achieve superior drying compared to our first generation therapies, and I think that is something that's exciting for our patients.
So those are excellent points on better drying, but how about better function?
Yeah, Colin, that's such an important question because function is obviously what our patients are going to care most about. But it's also tricky because you have to keep in mind that these studies were really non-inferiority design. So they weren't designed to look for superiority. So we have to kind of dig deeper into the data to try to see if we can figure out clues to this question. And so, for example, in the Tenaya and Lucerne trials, we see that numerically, the vision always seemed to be slightly better in the faricimab arm. And that actually led to an interesting investigation to see, is there a specific subset that might be driving this difference? And it did turn out that if you looked specifically at eyes with smaller lesions and a greater low luminance deficit, they did seem to actually have better visual acuity performance with faricimab compared to aflibercept 2 milligrams. At the same time, I would say this: we see that with the other second-generation agents as well. For example, we see in Kingfisher with brolucizumab, the brolucizumab arm always seemed to do slightly better than the aflibercept arm numerically. So again, they didn't achieve the margin that you would need to declare superiority, but again, they weren't designed for that point. So I think what we do understand, though, is that with faster drying, regardless of the treatment, you do get better vision in the long terms when we're talking about 1 and 2 years after therapy, because we understand that persistent exudation and having that fluid can ultimately be damaging for patients' vision.
I think the second part of the question is easy to answer. Are second generation agents longer lasting than first generation?
Colin, that's obviously an important question, but unfortunately, I'm going to give the same answer. It's tricky. And the reason is because, again, these trials were designed to get these treatments approved. And so they weren't specifically designed to answer that question. And one of the problems that we face then is that not all of the treatment arms were dosed the same way. For example, the aflibercept 2 milligram arm wasn't really allowed to be extended. So we can't directly assess that question of durability. At the same time, though, I think we can use our logic and our intuition to recognize that if you have better drying, it probably is going to be longer lasting or be more durable because, of course, all of us, we manage our patients based on the presence of fluid. And so I will highlight that even though one of the agents, aflibercept 8 milligram, we didn't really see this greater drying during the matched phase that we saw with brolucizumab and faricimab, it's important to point out that when we look at, for example, the sub-analysis and the photon study, it still took a lot longer for the fluid to reaccumulate in patients who were treated with aflibercept 8 milligram compared to 2 milligram. So we would expect that that should translate to greater durability with that agent as well. So, Colin, I want to switch gears a little bit. Let's really talk about how is it that these agents are used in practice? And, for example, how do you extend with these second-generation anti-VEGF therapies?
That's a good question. So generally with the second generation agents, I have the confidence to extend the intervals by 4 weeks because we've seen the efficacy and the durability. Even with aflibercept 2 milligrams, the LTEST study showed similar functional and anatomic outcomes with both 2 and 4 week extensions, so it didn't seem to make a difference. I might extend a patient by only 2 weeks if the patient has a condition that's been proven to be aggressive and difficult to treat previously, if it is a better seeing eye, or if the patient is anxious or not comfortable with a longer extension interval. And what intervals are you reaching in your own practice? How is this impacting your clinic?
Yeah, Colin, another important question. I would say that in my own practice, most patients with both neovascular AMD and DME, they're able to get to 12-week intervals. Some of them I can get to longer intervals, although having said that, I generally won't go beyond 20 weeks for patients with neovascular AMD. I'm always worried about recurrent activity. Although having said that, in patients with diabetic macular edema, after I get to a 20-week extension, at that point I will consider holding treatment and looking for any recurrence of fluid. Now, I would say in terms of what we see in our clinical experience, or what the impact of this is on our workload in our clinics, is that it has increased our capacity. So obviously, if patients are able to be seen at longer intervals, then we have more patient slots available. So it really has, I think, increased access for patients. And I really have this standard now that I really like to try to get every patient to quarterly therapy if possible. And obviously, that's more feasible now with second generation therapeutics. So Colin, let me ask you this question. With these longer intervals, I think it's been a boon for our patients. I think you'd agree with that. But do you have any concerns? How do you monitor patients in this new second generation therapeutic era?
Oh, yeah, that's an excellent question. Well, firstly, I do have confidence in the second generation agents because we've seen good and stable outcomes with intervals of Q16 or even longer, so that's reassuring. Also, post-hoc analyses of the clinical trials showed that more than 50% of patients could have been on Q20 intervals for both faricimab and aflibercept 8 milligrams. So sometimes if I intend to extend a patient longer, for example to Q20, I might bring them back for an OCT scan at some point in between the treatments so as to monitor the stability, and this is reassuring both for me and for the patient. Let me illustrate this with one of my patients. This patient presented with neovascular AMD, and this is his OCT scan at baseline showing very extensive disease. I treated him with faricimab, and after just one injection, you can see a very good improvement in the anatomy. And I then continued the loading phase and extended this patient rapidly. So here he is at Q16 with vision of 20/40 and no fluid. So I discussed with the patient, and we were both keen to try and see if we could extend him further to Q20. But as a precaution, I brought him back in about 18 weeks to monitor him clinically. So his vision improved to 20/30. Patient himself said he felt it was better, but on the OCT scan, you see a tiny cyst over there. So this was an early recurrence of the fluid at 18 weeks. Hence, I treated the patient with faricimab again, and not surprisingly, the fluid resolved. So I now know that his interval was maybe 16 plus weeks, but I'm slowly testing that margin of intervals again.
So Colin, that's really a powerful case. I think it's very helpful to see the potent resolution of the exudation and how you could extend the intervals. But clearly for physicians, that's been a great boon. But how do our patients feel about these extended intervals?
Yeah, that's an excellent question. Most of my patients are very happy about the ability to extend the intervals because this reduces the treatment burden and the frequencies of their visits. Now, there are a minority, who are concerned about the possibility of recurrence, and it's important to take their fears into consideration. For these patients, I would extend the intervals more slowly, just to show them that it is safe to do so. These patients also get a lot of reassurance from the extensive evidence in actual clinical trials, as well as real-world data, and as well as from their own clinical experience. So once I've shown them that they can be extended with no impact on their vision and no disease recurrence, they are more happy to be able to go longer, and I can then extend the intervals by 4 weeks. So thank you for this discussion. I think we had a great discussion.
Very much enjoyed it.
Yeah, so please continue to the next segment where I will recap the insights across this whole activity. Well, we've had some great talks, and thank you to all our great speakers. I'm going to summarize their talks. So from Vasada, we learned about the second generation drugs available today and how these differ from the first generation drugs. These aim to increase durability through an increase in the molar dose with aflibercept 8 mg, and also adding inhibition of Ang2 to VEGF-A by faricimab. Next, looking at neovascular AMD, Raj Mukherjee described results from real-world clinical studies including Spectrum, FAR-RETINA, FAR-WIDE, and Voyager, and reported that treatment-naive patients gained 3 to 4 letters with both faricimab and aflibercept 8 mg with stable vision in switch patients. The treatment frequencies were similar to that seen in clinical trials. With both drugs, we see about 4 to 5 injections in the first 6 months, and as patients are extended, it drops to about 2 in the next 6 months. Hamilmeta switched tracks to talk about DME, and the results in clinical trials are reflected in large real-world studies. Voyager and Spectrum showed good VA gains in treatment-naive and previously treated eyes for faricimab and aflibercept 8 mg, again with 4 injections in the first 6 months and around 2 injections in the second 6 months. We then went on to discuss the impact of second-generation therapies on clinical practice. We talked about the second-generation agents having faster drying, which may translate into better visual acuity outcomes. Thanks to the efficacy and durability of these drugs, it is now safer to extend treatment intervals by 4 weeks. And this has important implications for patient compliance, reducing the burden of treatment and lessening the demand for clinic space. For both neovascular AMD and DME, the number of treatments is reduced after the initial 6 months of treatment. This is seen both in clinical trial data as well as real-world studies. Thanks to the durability of these drugs, clinical trials showed around 80% of patients can be treated with intervals of 12 or 16 weeks, or possibly even longer. So thank you to our wonderful faculty for their insights today, and thank you for your attention. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.